Hello, ladies and gentlemen. Welcome to HAS 20 Virtual Summit Breakouts. During this session, you'll be able to submit questions and upvote questions from other attendees. The questions with the most votes will most likely be among the questions asked by the host to the presenter at the end of the session during the live Q&A. The bottom right tile box is where you can type in your question as well as click the thumbs up button to upvote a question. During the session on the top right tile box, you will also see a 5-question quiz based on the speaker's content. Enhance your learning by taking the quiz during the session and get points for your correct answers. All sessions will be available on demand, and if the presenter has given us permission, you will also be able to download the slides. Okay, it is now my pleasure to introduce Session 4, Machine Learning, Social Determinants, and Data Selection for Population Health. It is presented by Jason Jones, Chief Data Scientist, Health Catalyst, and Terry Steinberg, Chief Health Information Officer and Vice President for Population Health Informatics, Christiana Care. Enjoy the session.
Good day. This is the agenda that we are going to address in today's sessions. The learning objectives that we will focus on today are the following. We will explain how to assign relative value to population health data sets for inclusion in machine learning algorithms. Essentially, we will decide which data sets are important and how to do this evaluation. We will talk about some of the difficulty we encounter with acquiring, integrating, and maintaining various data sets. We will review how machine learning using a variety of data sources can be used to segment populations for a variety of reasons in care management and for focused care delivery. And finally, we will look at these learnings in order to define a strategy to select new data sources, to identify which will be easily included in our data models and which will be the most useful. At Christiana Care, we've been doing this population health machine learning stuff since 2012, and I mention this simply to point out that we have 8 years of experience. We're on a second-generation machine learning platform. We manage at Christiana Care about 100,000 lives in a variety of ways. We have ACOs, we have direct-to-employer contracts, we have partnerships with payers. And it's important to note that the Christiana Care Care Management Organization manages people who are not necessarily Christiana Care patients. So the lessons that we're going to talk about today can apply both to patients as well as to care management members who are someone else's patients. There are 3 key components for population health management. And I personally don't believe you can do a really good job unless you have these 3 components. The first is the technology to manage populations, whether that is an EMR that providers use to manage patients, or it's a specific care management application that care managers use. It's essential to have a customized population health application. The next component are analytics that will help you segment your population so that some people get more care, some people get less care, but everyone gets the right care. And then finally, it's the care managers. As you manage populations across a variety of venues of care, it's really important to manage the time between the episodes. And this is something that we've learned care managers are particularly well suited to. And so the focus of this analytic discussion today will really be on the use of machine learning and risk algorithms or prediction of risk by care managers. To some degree, this could apply to other populations as well. But when I refer to CareVio, that's the Christiana Care Care Management Company. The process that CareVio, the care management company, uses is really, it's a multidisciplinary team. The patient and the family are at the center. What we learned very early on in our journey towards risk is that one of the major benefits of risk contracts from a payment perspective is that The very services that cannot be billed under fee-for-service are those that are most important in determining outcomes. Things like food security, social workers, transportation, social aspects of care, pharmacists doing medication reconciliation. All of these services are very difficult to receive compensation for in fee-for-service. And so starting in 2012, Christianity aggressively pursued risk contracts with payers so that we could provide this multidisciplinary approach to care. An important component of that, obviously, is segmenting the population in terms of risk. In terms of hospital utilization, both 30-day readmission and unplanned hospital visits, when you compare the work that the care managers do for transitions of care to those who don't have transitions of care, you see almost half the utilization by people who receive care management intervention. Obviously, we use the tools that we're going to talk about today to guide how we do transitions of care and for whom we do transitions of care. The graphs on the right talk about utilization trends for hospitalization, for skilled nursing facility utilization, for emergency department visits, and for ED visits that lead to hospitalizations. And the different colored bars are different periods of time. But suffice it to say, when you compare the ACO that is managed using this risk stratification logic with the overall ACO statistics that theoretically do not use this risk stratification logic, the performance is much better. Really dramatic reductions in skilled nursing facility utilization days, short-term hospital stays, more than ED utilization, but certainly ED utilization also shows differences. So there are a variety of technology components that we use in our population health suite of applications, but that are really needed to realize risk stratification completely. And first and foremost is a population health EMR. We use a very standard system. It's used by most of the major payers, or I should say many of the major payers. It's the MedDecision Aerial system. And it's the population health EMR that is optimized for care managers. And we deliver our predictions, our findings, our recommendations directly into that workflow. We discovered very early on that if we asked our care managers to look at lists or to do something outside their intrinsic workflow, they did not achieve good success. So, lesson number one is give your care managers a tool that reflects risk so that they will know which patients to see and which patients not to see. It's important to be able to include your members or your patients in the technology stack, either through a member portal or a communication suite of applications or campaign management. And also to be able to manage people at home using biometric devices that the care managers that integrate into the care manager application. So the idea is that the care managers are managing these people between visits and they are monitoring the status all the time. So an important hallmark of the work we do is that if we manage 100,000 people, we are monitoring all of these people every day. And the data platform, the analytics platform that I'm about to describe, does that continuous monitoring. That's very different from the way a payer does care management, where they open and close cases. The third component, which in my opinion is the most important, is the data and analytics platform. This has various components. You can read about them. The goal of the data and analytics platform is to concentrate your data from all your sources, to perform business logic on those data that makes the data actionable, to deliver the data to the care managers so they can see it, to provide dashboards and other visualization tools so that you understand your financial and clinical performance, and also to perform predictions on these data so you can segment your population and pass those predictions on to the care managers so they can focus more on the people who need it and less on the people who don't need it. Interoperability and data concentration, or specifically interoperability, is really important because you have to deliver these findings to multiple systems. I wish I could tell you that we have an automated interoperability platform. Our interoperability tools are primarily human beings at this time, but we hope to grow in the future. And then finally, the real innovation that I mentioned earlier is to manage all the members all the time using this data platform. And it really allows you to scale up and scale down in terms of resources. You can manage as many people as you need to manage by simply setting your thresholds for notification at different levels. So the key to population health management, I like to think of as where's Waldo? You have to find Waldo, with Waldo being the people who need more or less interventions. And actually, you're probably not looking for the gray people who need less. You're looking for the blue people who need more. And those are the people who are going to make it to the care manager's work lists with various analytics. For example, you can set your spend, you can set your diagnoses, you can run a variety of analytics rules that will put people on work lists. And so it's automated. It's almost completely automated from the moment that the data element hits the database. So, we have many challenges in terms of data integration and consolidation. Patients receive care in many ways from many different healthcare organizations. Not all of the people that are care managed are patients at the same organization. Data are not integrated across different business entities. Different healthcare businesses tend not to like to share their data. Communication to providers is fragmented and it's difficult. And a single interoperable view that crosses all the business entities, all the providers, and all the ways the patient deliver care really doesn't exist yet. So fundamentally, the idea of acquiring and integrating data, which we fondly call data wrangling, is about 80% of the effort to perform population health technology projects. And not to mention the cost of acquiring the data in terms of licensing, mapping the data, and otherwise integrating it into a single platform. So the journey so far has given us a variety of lessons. The goal is to seek the few members who can benefit the most, and we use the analytics platform to stratify our populations to accomplish that. We don't want to overload our providers or our care managers with disconnected pieces of data. We would like to show success. We think we have shown success in a variety of ways as we move to increase our data capabilities. And the most interesting part, or at least a very interesting part, is how this all happens. So I'd like to turn this over to Jason now and ask him to talk about the data science.
Thanks, Terry. And as Terry mentioned, there are a lot of fragmented pieces of data. But the other thing that's difficult is those data are fragmented and incomplete, but they're also overlapping. So what we're looking at here, which sometimes reminds me of a petri dish, unfortunately, is we have the person that we're trying to serve and the outcomes that we're trying to improve for them. And the sources we have for inputs include electronic health records, health information exchanges, claims data, social determinants of health, and the like. And on the one hand, all of these together we know don't capture the entire person, where they are, where they'd like to be, their goals, et cetera. But the other thing is there's a lot of overlap, right? So an EHR is what sends data into a claims system. So if you have both the EHR data and the claims system, there's immediate overlap. But there's also a lot of overlap with the health information exchanges and social determinants. So one of the things that we tried to figure out is what's the most efficient way to present information to a care manager so that they can feel confident using what they have and not be overwhelmed. So the job for a predictive machine, and the predictive machine is the thing that's going to help us figure out, as Terry mentioned, whom should we focus on? Who would benefit most from the types of outreach that we have? And the first part of that is identification. Can we help find Waldo among everybody else? Then can we segment people who are similar, perhaps based on clusters of need, so that when a care manager reaches out, she or he has some idea of what types of services might be beneficial for that person at that point in time. And lastly, optimization. It's very, very rare generally in health and healthcare, but especially in population health, to know exactly how to reach out to whom and when and what they're going to need. And so how do we set up a learning plan to help us really optimize that outreach and impact over time? The first question that we get asked is, how can we prioritize the resources? What types of resources they need, and then how we optimize. And the data that we just have some fake patients here, some fake people, A through G, and they're just sorted alphabetically. And then we have a bunch of features for them. We have some numeric features, we have some categorical features. We often have hundreds and hundreds of features that we could use about their clinical or other circumstances. And then we have something that says, what was the outcome? Was it good? Was it bad? Was it in the middle? And what we're really trying to do is to figure out how it is that we can take the information that we have and represent it to care managers and to others in such a way that they can use. So the first thing that we're going to do, and as we go through this slide, the blue parts are the parts that machines do well, and the purple parts are the parts that people do well. It's really important to bring together both parts because neither the computer nor the machine does everything perfectly. Computers are really good with math. So how can they help? Well, we start, and let's not forget that it's the humans who donate our data, whether those are physicians or nurses or care managers or the members themselves. They're donating data, and we still need them to donate the data disproportionately. We don't gather them automatically. It's important to remember that. And the next thing is that the computer can take and sort those members based on risk. So that's the first blue column. And that's something that a computer can do really well. And now you'll see, instead of just being sorted by alphabetically by last name or something, we're now sorted based on their risk from 0.9% of, 90% of whatever that bad outcome was to 20% of whatever that bad outcome was. The part that the human needs to do, to Terry's point, is the human will understand what the benefits of outreach might be and what the resources are available to provide that type of outreach. And so it really takes a human, and specifically a leader, to be able to help us set those action thresholds, or as Terry mentioned, dial them up or down based on our understanding of the population and the resources that we have. So imagine that the red line right below person F is where a person would set a threshold and say, yes, the people above are where I would feel good that if a care manager reaches out, she or he could have a beneficial impact. And we have enough care managers given that population size to actually do the work. The next piece the computer can help with is to help us create some segments. So it could be that two people have exactly the same risk for whatever that bad outcome is, but for very different reasons. You might have one member who's had a recent bad illness and another member who hasn't had a particularly bad recent illness, but has a bunch of chronic conditions altogether. So the segmentation can help us understand what types of resources might be beneficial, what type of a member are we looking at. What often gets left out of this process is how to design for learning right up front. How can you design to really optimize the actions that you're taking? And the other part that the computer can help with, or the machine can help with, is to assign resources in a random way. And this can often scare people because it sounds like a randomized controlled trial, but the reality is, especially in population health, we typically find that we have far more members who might benefit from that outreach than we have resources to allocate to them. And so it's quite reasonable in that point, if we're not exactly sure what the best approach for outreach is or what the best interventions are, and we're limited in resources, if both of those are true, we can use the machine to set up a system whereby we're allocating those resources in a reasonable and yet random way. So we're not leaving people out who could benefit if we had the resources to take care of them. But at the same time, that really helps us learn much more quickly and optimize our actions going forward. A lot of people have seen the wonderful things that AI has done in the imaging world. And this is a favorite picture from Karen Zach from a few years back about how it is that computers were trained to distinguish between dogs and chicken. And someone else will know what kind of a dog that is. I know that's fried chicken. And there's some similarities that we're going to see between health and healthcare and this type of AI task. First off, we still need people to provide the labeling. There had to be an initial set where people said, that's a dog, that's fried chicken, that's a dog, that's fried chicken, so that the computer could learn. And humans are also responsible for determining whether or not there's value in separating dogs from fried chicken. The part where we distinguish health and healthcare from AI in this imaging space is that the reality is we would expect most 3 or 4-year-olds to be able to figure this out, to be able to distinguish between a dog and chicken and be able to say it, perhaps even a 2-year-old. So it's impressive that a computer could do it, but for a human being, this is not a problem. The other thing that's different in health and healthcare from AI is in this problem, we all immediately know what the right answer is. We all immediately know what happened. We knew which the dog was. We knew which the fried chicken was. But for population health in particular, we may not have visibility into the outcome. Even a short-term outcome like a readmission could happen at another hospital in a different state, let alone the things we're really aspiring to help our members with, which could happen 5 or 10 years down the road. So we often lack visibility into exactly the quality of the outcome that we're able to achieve. Even CMS has started to realize how important it is to ensure that we can explain the complex predictive models that we may be able to build. And once again, here, there's a reason why. The reason is because disproportionately in health and healthcare, the output of the machine does not directly determine the outcome or even the action that we take. There's typically a human being in the loop. As Terry mentioned, it's a care manager who's going to look at this risk score and decide what to do with it, even if it just changes her or his tone or how they start the conversation. There's almost always a human in the loop, and as a result, it's much more important in predictive models in health and healthcare that we be able to explain why the computer is working the way that it is so that human beings can trust it and be willing to act upon it. We have a very well-defined process for how it is that we build predictive machines, and we're going to focus on one piece here, which is just the building. But just to point out, as Terry mentioned, 80% plus of the effort is really engineering at that defining stage of can we identify the populations and the outcomes and features and bring together all the disparate data sources that we have. Once we're done with building, which we're going to focus on, we then need to make those critical decisions that human leaders typically make, like where is it that we should set thresholds. We then need to deploy the model, as Terry mentioned. It's not okay to send around a separate piece of paper, Excel sheet. You need to be able to figure out how you embed it into the workflow of the people who are going to take action. And we've spoken already about optimization, but here we're really going to focus on the building part. How is it that we identify the best, but also the most efficient and explainable model that we can for the care managers who are going to be using it? So within there, we're going to take a look at a couple tools. The first thing we're going to look at is just understanding over, in this case, almost 800 features, which are the ones that seem to matter most. Then we'll go to the next step of building the most efficient model that we can. And lastly, again, incorporate a human into the loop about selecting from the possible features, even within those efficient models, to make sure that they make sense and will be believable by the users. So this is an actual screenshot of a model that we ran. And what we were looking at here on the right-hand side, you'll see a whole list of the features. In fact, there were 799 candidate features in this model to try to predict who will be admitted to the hospital in the next 90 days. And there are two columns to the right-hand side. One's called multivariable, the other one's called univariate. The univariate column is how much does this feature help us understand a member's risk if it was the only thing that we knew about this member. And you can see that there are a lot of features that are very, very close to each other and quite high. The range of that value is from 0.5 to 1, 1 being perfect prediction. So when you see an individual characteristic that's already at 0.79 or 0.8, that means by itself it's doing really, really well. The next column to the left with the blue bars is looking at how much does this feature tell us about this member's risk given everything else that we know about the member. And there you can see a much, much steeper drop off, even though those top two predictors individually are incredibly helpful. When you put both of them in the model, there's a terrific amount of overlap between them, and they don't add incrementally that much information to each other. What's highlighted here, and one of the things that we had focused on and were very, very hopeful for, was that the social determinant of health data would add a lot to the predictive utility of our models. And you can see highlighted and fairly low down, they're just not adding a lot. And in fact, the first social determinant of health feature that makes it into the model would have been age, and we can get age from other places. So this is a tool that we use to understand the feature importance from a trust building perspective. It allows those users to understand that it's not that we didn't consider their pet or favorite feature, it's that we did, but we looked at it in the context of everything that we knew. Features can be very, very useful individually, but often they share a lot of information between them. There's a relationship, obviously, between temperature in Fahrenheit and temperature in centigrade, but it's also the case that diagnoses are highly related to what shows up on the problem list, and different comorbid conditions can be identified either by lab values or diagnosis values. So it's important to understand not just that the feature may be important by itself, but that adding more data doesn't necessarily lead to more information. So the next step that we take after looking at all the features that we might is to try to build the most efficient model that we can. And we have a specific process and set of tools for doing this. We're looking at an example screenshot on the right-hand side where it goes through and does add each feature, trying to find the most efficient model that it can so that it's simple and easy for the users to know why it is that the model's working the way that it is and why it is that they might be able to trust it. Importantly, generally from a model building standpoint, the techniques that we use do avoid overfitting, which is when the model does really, really, really well in the training data that you gave it, and then does really poorly in the real life world. But the other thing important about this particular tool is it does allow people to explicitly state their preferences. And this is a key part of trying to keep the human being in the loop. And why might you have preferences for features? Well, it could be that some features literally cost more financially. Consider an X-ray versus a CT, for instance. Or it could be that there's licensing costs associated with it. But just as likely, it could be from a care manager's perspective that if the information is not available without surveying the member, that there could be a lot of effort and disruption both for the care manager and for the member before we can capture the information at all. And so these are some of the types of reasons why people might state preferences for certain features over others, and the modeling techniques that we use will incorporate these preferences to try again to build the simplest model that we can. While recognizing the preferences that the human users and beneficiaries may experience. Here, it's just to note that there are different modeling techniques that we can employ to try to build that most efficient model, and we'll often review several of those with users, especially the leadership, so that they can select the ones that make the most sense, and again, allow their preferences to come forward. These are the features. Remember, we started with almost 800 of them, and we thought it might be interesting for people to see how across 3 different outcomes in the same target population, we have different features that get selected, but also a lot of overlap. So those 3 targets that we were looking for were inpatient admission in 90 days, emergency department visits in 90 days, and whether the member was likely to expire in the next 6 months. And you'll see that there's a lot of overlap. For instance, the CMS HCC risk score was a top predictor both for inpatient days, inpatient admits in the next 90 days, but also for whether or not the member might expire in the next 180 days. If you look down at the labs, you'll see that labs are often important, but different labs are important in different contexts. So for instance, the white blood cell count is important for hospital admission, whereas the albumin is more important for the ED visits, and the total number of abnormal labs were most important for the member expiring in the next 6 months. So conceptually, there's some overlap. There's some overlap in actual just features themselves, but it's important, again, to build a model that will stand up and make sense to the users and the leaders. Many of our clients come to us and say, can't you just give us a model that you built somewhere else and apply it in our circumstance? And the answer is often no. But the important thing is that it's really, really, really easy today to build a model. As Terry mentioned, 80% of the effort is getting the data together. And once you've gotten the data together and you've tested your model, you essentially get your own predictive model for free. There's almost no effort that's involved. But why it is that we would like to do this in a pop health situation is as follows. First off, the populations are often very different from each other. Some populations are disproportionately Medicaid. Others have, as Terry's populations did, a mix of commercial Medicare and Medicaid members. They're in different parts of the country or outside the United States even. Different organizations have access to different data, not just what it is that they can get, but how they capture it and how it runs through their systems. And so we actually find that there's very low portability of models from one organization to the other. And that's okay, again, because it's so easy to build these things today. It really doesn't need to be a stumbling block. The hard part will be building the data set in the first place. The thing that we find most underestimated in terms of value is model retraining. And there's something specific, a couple specific things to keep in mind here. So the first thing to know is that you really, really, really hope that the predictive performance of your model gets terrible. Why would that be? The reason is because if your predictive performance is high before you start intervening, this is a good sign. It means that you can help separate out, find the Waldos who really could benefit from your outreach. But ideally, you have that model paired with a great intervention. And so now all of a sudden, your model is going to be saying so-and-so is going to be at risk for an inpatient admission or something else. And you carry out the perfect intervention to prevent that from happening. And now it looks as though your model is wrong. So you hope over time that your model performance goes down. What's important is to understand why is it going down. And in order to do that, it's critical to capture what the interventions are so that the machine has a chance to separate out how much of this poor model performance is coming from the model just performing poorly. The data have changed, the risks have changed, something else has changed, versus no, it's the intervention that's working. We don't want to change the predictive model at all. We want it to perform exactly as it is and keep guiding our hand in who could benefit most from our interventions. It's really important also to not set up machines that try to learn themselves. Establishing causation is another area where it is really important to have people who understand the processes and understand possible causal linkages involved in the process so that you can really help tease out correlation from causation. And now we'll turn it back to Terry. Thank you so much.
Thank you, Jason. So I'm going to spend a few minutes talking about the human beings and how they view all of this, which we really group into the psychology of people who use the models. And, from the School of Hard Knocks, I can say that getting people to actually believe these models and use them was very difficult. Some of the reasons ranged from the fact that care managers are nurses and they want to call everybody, and they just simply couldn't focus on the people who are at high risk. And then the other spectrum that they didn't believe the models. So for these reasons, it's very important for your care managers and your leadership, clinical leadership, to understand how the model is developed, to share precision information with the users so they understand how well the model is working, including how it was designed, what are the targets, and what are the most important features. It's really a good way to ensure that people understand the importance of these models, as well as to the best way to deliver care is to make sure that the interventions that you provide are customized based on the risk. So we risk stratify our care plans, and if the care managers are notified of an emergency department visit for a low-risk person, they may behave very differently compared to an emergency department visit for a high-risk person. And, constantly, the care managers and the people who monitor the care managers have to be aware that they need to let the risk level drive what they do, and that they need to let the machine drive care. Which is not to say that they don't ask questions about how well this relates in the real world, but they simply need to have confidence in the model. What we also learned early on was that the raw numeric scores that were delivered by the analytics platform was really too specific for human brains to wrap themselves around these numbers. The difference between a 0.05 and a 0.06 may not be something that humans can relate to and act upon. So we basically decided to have 4 different risk categories, and based on the numbers, to put all of our members into one of the 4 buckets. That also makes it quite easy to monitor rising risk in addition to, high, low, medium, and low and lowest. Well, high, next highest, you get the idea. So the categories of risk become much more important for human interventions than the raw numeric risk score. And at the same time, it really ensures that people don't manage to the 100th of a decimal point, and that they look at the overall human being. So some recommendations and key learnings is that if you tell your users how the models work, you familiarize them with the outcomes and with the signals that are important, they will develop confidence in the score that you're presenting to them. In the same vein, if you can reduce the number of features that contribute to your model and to this risk score to the smallest number, you stand a chance of being able to deliver that information to your care managers. You might say 8 is better than 800, and you might be able to say, this person is in the highest risk category because of a claim, or this person is in the highest risk category because of a lab result. The care managers have access to all of that information, and this will begin to resonate with them. So more information to care managers is better than less. You need to make sure that the care managers are using critical thinking skills. Does this score match what I'm seeing in terms of the clinical data, the claims data, and other information that's coming across? And you need to constantly be asking yourself, are these data sources, is this method the best way that we can deliver care, that we can provide care management? Some of these data are very costly to acquire and maintain, and the simpler model is the better. So we are not shy about trying out data sources and then at the end of the day, rejecting them. An example of this that I'll share with you is that we acquire a commercial social determinants of health file. We were very excited. We thought it would be very useful. It's rather expensive. We included it in our model. We did our analyses and discovered that it really wasn't adding much to the information that we already had. So this is a journey of discovery that we have been on for 8 years, and we are not nearly at the end of that journey.